So let's look at patient assessment. So we're going to, of course, make sure that the patient's scene is safe. If there's anything that could be a threat to you that causes their allergic reaction, then we want to stay away from that and keep ourselves safe, of course. Be mindful of other potential causes for respiratory distress and consider the need for ALS. Again, there's a lot that you can do, and you don't want to wait for that ALS personnel to get there to start your treatment, but you definitely want to consider them. If you don't see any changes in the patient after that first round of epinephrine, then you might want to go ahead and start calling ALS just to get them on the way there to you. Looking at the primary assessment, we want to quickly identify and treat any immediate potential for life threats. And again, the life threat here, the way we're going to treat that is with epinephrine. There are other medications that we can give to help alleviate some symptoms, but what is truly going to make the difference in treating the life threat is the epinephrine. We want to form a general impression of the patient. We're trying to look at, is there any respiratory or cardiovascular distress here? These patients will often be very anxious. We want to ask them questions like, has this ever happened to you before? And if so, what happened? That's important for us to know how their last allergic reaction or attack resolved. Looking at airway and breathing, remember this can be a cause for rapid swelling of the upper airway, so looking for swelling of the airway and also listening for bronchospasm of the lower airway with wheezing. So we could hear stridor and or wheezing here, and we want to make sure we're working pretty quickly to determine the severity of the symptoms. So we're assessing for increased work of breathing, use of accessory muscles, head bobbing. Is the patient in a tripod position? Do they have nostril flaring, abnormal breath sounds? Again, stridor or wheezing are going to be some of the most common things for us to consider. We want to assist the patient into a comfortable position to help maximize ventilation. If there are signs of shock, place the patient in a supine position, but remember that this is probably going to be an issue with their breathing. So if they're struggling to breathe in that supine position, then definitely sit them up. We can give them oxygen as necessary, so go ahead and have your partner get that patient on some oxygen while you're drawing up that dose of epinephrine. If this is a really severe situation where there's an issue with the rate, rhythm, or quality of ventilations, then we want to go ahead and assist with ventilations if the patient is tolerant. Most of these patients will be breathing rapidly, some even more than 28 times per minute, which is usually where we would start to get concerned. So we want to look to see what's happening here. Are they going to be tolerant of those ventilations? We're looking at circulation. Is the patient presenting with hypotension? Do we have any other signs of hypoperfusion? Remember, our treatment for shock for this patient is going to be epinephrine is going to be our definitive treatment. We can also give those other medications, but that's the biggest concern here. We also can think about temperature management as far as helping to maintain the body temperature as the patient progresses more into shock, which we hope we can reverse rather quickly. Usually we will start to see the effects of that epinephrine within about 30 seconds to a minute. Looking at transport decision, we want to provide prompt transport for any patient who's experiencing an allergic reaction. If the patient does not exhibit these severe symptoms, you can continue your assessment en route to the hospital, but we definitely want them to be evaluated, especially if this is their first time or if this is more severe than any other reaction that they've ever had. Looking at the history, again, we want to ask about, has this ever happened before? What were you doing when this started? What are your signs and symptoms? And these are just a few examples of those signs and symptoms. I'm not going to read through all of these, but you can see that it can be as mild as just sneezing, an itchy or runny nose, or all the way up to unresponsiveness, cardiovascular, and respiratory collapse. We want to get that sample history, specifically asking the following questions. Have any interventions already been completed? Like, have you already used an EpiPen if you were prescribed one? And have you ever experienced a severe allergic reaction like this in the past? And if so, again, what was the outcome the last time this happened? We want to be alert for any statements regarding ingestion of foods that could cause allergic reactions. So again, thinking if they're not sure what caused this, asking about their last oral intake. Is this new for you? Is this the first time you've had it? And we can also ask about gastrointestinal complaints specifically related to nausea and vomiting that could go hand in hand with this. We're going to do our physical examination, performing a systematic head to toe or focused assessment depending on the patient's presentation. If they're unresponsive, invasive, we would want to do a full body hands-on assessment. If they're not, then we could go with the focus or medical assessment. We want to auscultate for those abnormal breath sounds. We're looking for skin temperature, color, and condition, and also the presence of any hives or wheals. We want to assess our baseline vital signs. Skin signs can potentially be unreliable as the body begins to shunt blood in towards the core and away from those peripheral sites. That might not be the most reliable indicator, so we want to make sure we're doing a good assessment. We can get pulse ox on the patient in addition to our other vital signs. End-tidal would be something good to have here. And again, considering applying oxygen to patients who are having severe increased work of breathing and abnormal lung sounds in addition to the medicines that we're going to give as well. We want to repeat the primary assessment and reassess the patient's vital signs every 5 minutes if they're unstable and every 15 minutes if they are. And we're going to go ahead and watch for those signs of shock, making sure that we're staying alert to them, treating for them as early as we can, and providing rapid transport to an appropriate facility. As far as interventions, we want to determine the severity of the reaction. Mild reactions might just require supportive care and maybe just some Benadryl by mouth. Anaphylaxis, again, is going to require rapid administration of epinephrine, oxygen probably. If they're having enough wheezing here where we're starting to get concerned, we could consider administration of a bronchodilator like albuterol or Xopenex if they had been prescribed before. If not, we would need to contact medical control. And then if the patient is able to swallow, if they don't have a whole lot of swelling in their throat or mouth, then we could consider administering Benadryl by mouth in an appropriate dose for that patient. And then, of course, we want to document everything, all signs and symptoms, why you chose to provide the care that you did, and what was the response to that treatment, what was the eventual outcome. Again, just following up on the care here, if the patient appears to be experiencing a severe allergic reaction, we want to go ahead and put oxygen on and administer that epinephrine as quickly as we can. If there's a stinger present here, we can scrape the skin with the edge of a sharp, stiff object like a credit card, but you should never use tweezers or forceps. That can actually cause more venom to be injected from the stinger into the skin. You want to go with the grain of the stinger. Don't go against it because you don't want to break that stinger off into the skin. Be alert for signs of airway swelling and other signs of anaphylaxis that could potentially develop throughout transport. Again, you can put them in a supine position if the hypotension is a main concern or the patient is experiencing syncope. But if they're having a lot of trouble breathing, probably want to let them sit in a position of comfort, which is probably sitting up or in a tripod position. Continuously monitor their vital signs for changes. And then as far as the epinephrine, remember that can be 0.3 to 0.5 milligrams for adults and then 0.01 milligrams per kilogram for pediatric patients. And so this epinephrine injection is going to mimic the sympathetic fight or flight response, and it helps to rapidly reverse the effects of anaphylaxis. So again, you'll probably see the effects of this medication within 30 seconds to a minute of injection. This can be prescribed by a physician and come in a pre-dosed epinephrine injector like an EpiPen. So if the patient is prescribed an EpiPen, ask them, do they have it there? Have they used it? We can refer back to local protocols and consult medical control if we have any questions about this. If the patient requires a second dose, you will need to contact medical control. The adult EpiPen, if they have one there, delivers 0.3 milligrams of epinephrine, and the pediatric one, the EpiPen Junior, delivers 0.15 milligrams. So remember, you need to know both doses, both the auto injector and then also what it would be if you draw it up out of a vial or ampule. Some potential side effects of epinephrine: high blood pressure, increased pulse rate, anxiety, cardiac arrhythmias, pallor or paleness, dizziness, chest pain, headache, nausea, and vomiting. So some other things just for us to be alert for. Ultimately, we know that in this situation, it is life-threatening that the patient receive this injection, so they might need some additional treatment for these side effects depending on what they are. If the patient starts complaining of chest pain, we definitely want ALS to be there if they're not already, to be able to look for those cardiac arrhythmias with a 4 and 12 lead EKG. But definitely want to just stay alert to the situation. We should not give epinephrine to patients if they're not experiencing signs of anaphylaxis. So if this does appear to just be a localized reaction, then we're not going to give this. We would go ahead and just give the Benadryl by mouth like we would for a local allergic reaction. That's going to play on the histamine receptors and help decrease your hives and itching. So that's it for this. If you guys have any questions about this chapter, all of this we've pretty much talked about before, just kind of sporadically. So this was putting all of this information together. If you have any questions about this chapter or any other, then please feel free to reach out and let me know.